It's on. Now it's on. Good morning, everyone. We're going to get started here. My name is Rita Moskowitz. I'm part of the faculty of the Division of Pediatric Emergency Medicine. I started here at the University of Minnesota in 2016 by way of Children's Hospital Los Angeles. And I'm also have joined the leadership on the for the Pediatric Global Health Tract this year. So, along with Drs. Tina Slusher, Cindy Howard, Mike Pitt, and Sophie Gladding. And it's my privilege this morning to be presenting to you the resident projects from their experience over their globally infused residency. We have no conflicting financial relationships to disclose to you. And this morning, by the end of our presentations, we hope that you'll be able to discuss the scholarly projects of 4 of the Global Health Track residents, explain unique ways that the residency training is enhanced by global health experience, and recognize some of the challenges of global partnerships and research. Just to give you some background, the Global Health Track here at the University of Minnesota was established in 2005. It's had 129 graduates to date. It is a competency-based curriculum, which is unique and was one of the first in the United States to offer such in pediatrics. This includes educational half-days with global health curriculum core topics, monthly discussion dinners, online modules and courses, recommended readings, reflective writing assignments, and clinical and public health elective options for residents. This past year, we piloted something called the Global Health Passport, which is taking a novel approach to individualizing the curriculum to better enable busy residents an opportunity to achieve specific learning objectives through the completion of one of several offerings. Residents log their completion, they provide feedback on their experience, and keep track of their progress through the curriculum by quarterly generated reports. This picture here is an example, just a screenshot from the passport, where you can see, for example, at the top, the learning objective number 28 is caring for international adoptees and gives the options to achieve that learning objective through either completing the international adoptive elective, a GPEDS online module, or attending a block ed educational series session on that topic. In terms of global health electives, residents may do them internationally. There are also local global options to work with refugee and immigrant communities, Native American health, adoption medicine, and a 1-month global health course through the Department of Medicine. Prior to participating in international electives, residents must complete pre-departure training. In the fall of 2017, the University of Minnesota hosted the Midwest Consortium of Global Health Educators annual meeting, and during that time, coincidentally, the pediatric pre-departure training also took place. As a spinoff from there, leaders from the consortium, led by Dr. Mike Pitt, then collaborated to develop and disseminate a pre-departure activities curricular kit based on the University of Minnesota's model, which is a comprehensive, modular, modifiable pre-departure curriculum for medical providers planning to work in resource-limited settings abroad. So with that, I'd like to invite our first resident speaker up. His name is Andrew Wu. He's an UMNPeds resident in his 3rd year, and first became interested in global health issues during doing some volunteer medical outreach work in low-income Hispanic communities in college. He's also done short-term clinical work abroad in El Salvador, Ghana, China, and most recently Cambodia. As a physician in training, Andrew believes his global health experiences have helped him be a more adaptive physician and diversified his communication approaches. He hopes to continue working overseas as a clinician and a researcher following residency.
Great, thanks. Can everyone hear me okay? All right, cool. And pointer. So there's not a pointer, is there? Like a laser? That's cool. I'll use a mouse. All right. So thank you very much, Risha. So thanks everyone for coming this morning. My name is Andrew Wu. I am a MedPeds resident here at the university, finishing up my 3rd year. And I had the wonderful opportunity of going to Cambodia this past February for my clinical rotation. But I also conducted a really brief chart review while I was there. and that's primarily what I'll be talking about in this PowerPoint. So just to begin, some of you may recognize this figure. It's from Lancet in 2013, and it's from their Global Burden of Disease study. This figure specifically looks at the cause of mortality in children under 5 around the world. And as some of you may already know, pneumonia is and continues to be the single leading cause of mortality in children under 5 around the world. Now, there was another study, came out, same journal, same year, that attempted to look at the geographical distribution of the burden of pneumonia. And what they found is that most cases occur in either sub-Saharan Africa or in Southeast Asia. And if you didn't know, which is okay, Cambodia is located in Southeast Asia, and so given my prime opportunity to be there, I thought it'd be a great opportunity to look at the burden of pneumonia there. So Cambodia is categorized as a low to middle income country by the World Bank. The mortality rate in children under 5 is about 6 times higher than that in the US. Where I specifically was in Krache town in the province of Krache. And the province of Krache is among the 4 eastern provinces of Cambodia. And these provinces are collectively known to be very rural and also to have the highest mortality and morbidity indices in every age bracket in this country. To put this into numbers, for every 1 death under 5 in Phnom Penh, which is the capital, there are approximately 5 under 5 deaths in Krache town. And this really highlights the health disparity between the urban and the rural sections of the country. And the doctors that I worked with attempted to bridge this gap between these two worlds. So I worked with were the Houseworths. And the Houseworths are 2 MedPeds physicians. They're actually US trained, but they've been in Cambodia for the past 10 plus years, working as medical directors at one of the children's hospitals in Cambodia in one of the urban settings. But like I said before, they wanted to bridge this gap. So they replicated their model in rural Krache and created Chenla Children's Healthcare. So this is a group that they lead, and it runs a 30-bed pediatric ward in Krache town, which is where I did my work. So because of this, large burden of pneumonia around the world, and my unique opportunity to be in Cambodia, I wanted to see if I could contribute somehow to what they were doing. And so within the framework of a needs assessment, I wanted to try to quantify their burden of pneumonia among the kids hospitalized there. So the methods were real straightforward. They only use paper charts. And so I took the data from these charts and put them into a digitalized form so I could easily analyze it. I looked at a 10-month period from the period that they started in April 2017 up until the month that I was there in 2018. And after looking at all the different admission diagnoses that these kids came in for, there were about over 80 or so, I deemed that the kids who came in with any of these 3 diagnoses could be classified as coming in for lower respiratory tract infection. So in total, I found that there were 1,300 kids. And, oh, sorry, I forgot to mention this. I specifically looked at between 1 month and 5 years. Sorry about that. So I found that in this age range of interest, in that 10-month period, there were 1,300 kids that came in. As you can see here, where the x-axis is the age in months, and then the y-axis is how many kids came in, you can see that almost half of those 1,300 kids were infants, or kids under 12 months of age. The other thing I want to point out is that almost half of those infants came in for lower respiratory tract infection, so really highlighting the prevalence of that disease. So then my next question I had was, okay, well, that's interesting that so many infants came in. How about we zoom in on that age group? And that's what I did in this figure. And so now you have the same information, except on the bottom, it's aged by, 1-month-olds and 2-month-olds and so forth. And so again, the younger kids are overrepresented, and I'll get to that a little bit later. And then the other thing I want to point out is also, again, almost half of the admissions come in for lower respiratory tract infection up until about 5 to 6 months, and then it starts to teeter off. Okay, 2 more figures. So this next one, I just want to highlight that among the 1,300 kids that came in, and all 1,300 are represented in this pie chart on your left, about 1 out of 3 came in for lower respiratory tract infections. And again, this is between 1 month and 5 years. And unsurprisingly, most of those admissions were in infants. Okay, so this last figure I find to be particularly interesting because I looked at the kids who had poor outcomes, which I specifically defined as either needing to transfer out of the hospital for higher level of care or they died. And on this, the entire, bar on the left represents all the kids, not just the 8 kids that I looked at, not just the 1 month through 5 years. And in total, there were 113 deaths or transfers out, or basically 113 kids in that 10-month period with a poor outcome. And then the top orange rectangle are the kids that I specifically wanted to look at, the 1 month through 5 years, and there are 46 of those kids. So almost half, a little bit less. And then I blew that up to kind of see how many of them came in with lower respiratory tract infections, and it was 13. So 13 out of the 46 kids came in for lower respiratory infections. So 13 out of 46, about 28%. And that's why I find this figure interesting, because it provides kind of an indirect but relevant correlate to that 13% that I mentioned earlier in the Lancet figure, because they report 13% mortality is from lower respiratory tract infections, and in this population, in this very brief chart review, it's about 28%. So 2 quick questions that came to my mind as I was going through this data, and I just wanted to share my thoughts with you guys. So 1, why the significant decrease in lower respiratory tract infections as kids get older? And I say significant, I didn't statistically analyze it, but it just seemed steep. So one thought is, well, you know, as kids get older, you know, they get exposed to other things that they can eat. And so the risk of other diseases besides respiratory infections goes up. So for example, gastroenteritis goes up, dysentery goes up. And in fact, when I went through the data, the second most common diagnosis in infants was gastroenteritis. And then probably in the older children, one of the most common diagnoses for coming in was gastroenteritis. To back this up too, going to the figure from Lancet, as you can see, one of the big causes of mortality is diarrhea. And so that makes sense from that hypothesis standpoint. The other hypothesis that I had, which is very unique to this population, is this custom that occurs in rural Cambodia. It's very commonly done where they have neonates as young as 1 day old sleeping at home directly above a burning pile of wood. No active flame, but there is active smoke. And sometimes they do this up to a week, sometimes they do it up to 9 months. On average, about 6 to 7 months is what I was told. So the thought is that it keeps them warm at night. It makes them stronger when they grow to be older. But as you can see, this also poses a respiratory risk. The other question that I had is why infants were overrepresented in this study. Do they get sick more often? And then I thought, well, maybe this isn't just like a Cambodia phenomenon or a low resource phenomenon. I looked at US data back in 2000 from AHRQ, and as you can see, infants are just hospitalized more often than their older counterparts. And as far as why that is, I guess that delves into another question that I'm not going to explore here, but I just wanted to mention that I didn't think it was necessarily just an overseas phenomenon. And then my next hypothesis for why infants were overrepresented, which I don't think is valid at all, but I was grasping for straws, was like, are there just more infants in the population? And then the infants who do well grow up to be older, and the infants who don't do well pass away. I don't think that's the case because I have not really any census data to back that up. When I go back through my data, among the 10 kids who passed away, 9 of them were infants. But I think that's more just because more infants were, again, represented, not necessarily that more infants were more likely to pass away. Okay, so in conclusion, low respiratory infections, really high prevalence here. Second, the infants are disproportionately represented, and low respiratory tract infections make up more than a quarter of the poor outcomes in this age group. So as far as how this data is going to be used, when I was there, they actually started conducting home visits, which I thought was really great. And I encouraged them to develop kind of a risk stratification strategy where they go in with either with a survey or something like that in order to produce a health education, I guess, curriculum for the patients in the community. And with this data, that they can then stratify what they use for their education. So for example, if they go to a home with an infant, then they can target their strategies for pneumonia prevention. So for example, seeing if there's a smoker in the home. Whereas for the older kids, they can look at how they're, kind of where they're getting their food and where they're defecating and things like that. The other way that I'll be using this data is I'm actually working on a research project with Dr. Tina Slusher and Dr. Ashley Bjorklund. And Dr. Bjorklund was a recent PICU fellow graduate from here. She basically invented a low-cost way to adapt a device called bubble CPAP for use in older children. And we'll be testing her device in a couple of different international sites, and one of them is going to be at Chenla. So we hope that this information will help inform that hypothesis and study design. So So I'd like to thank a few different groups. One, of course, Chenla Children's. I am friends with them up until this day, and they're just fantastic people. We still WeChat all the time. They blow up my phone. I'd like to thank CMDA for all of their support as well, and last but not least, the Department of Global Peds for being so supportive and helping integrate this experience into my residency education. Thank you.
So in terms of questions, I'm going to hold those until the end. We'll do all the questions for the residents at the end. So thank you, Andrew. Our next resident speaker is Ife Ojo. He's been a part of our global, he's been our global pediatrics chief resident this past academic year, and was before that also a resident here at the University of Minnesota. He was born and raised and studied medicine in Nigeria, and is passionate about addressing global health disparities that affect low middle income countries as well as refugee populations. He has extensive research in global health. He's conducted public health research across 9 other African countries, which I feel is good always to mention. I feel often Africa can get lumped into this continental, almost like a country, but there's so much ethnic and cultural and country diversity within it. So the 9 other African countries that Ife identifies he's done research in include Cameroon, Ghana, Kenya, Liberia, Malawi, Sierra Leone, South Sudan, and Tanzania. He also spent time in Nicaragua for his MPH field experience, and during residency went back to Nigeria and worked with Dr. Tina Slusher on the Filtered Sunlight Phototherapy Project. This year as chief, he returned to Cameroon. And also, I just want to mention that he did identify that the global health component of our program that we offered in pediatrics was a main draw for him to come to Minnesota. And he hopes to continue to do global health work in his future, in particular focusing on education and capacity building.
Thank you so much, Alicia, for that introduction. I am Ife Ojo, and I'm really glad to be here this morning. I am in the last few weeks of a very exciting year as a Global Pediatrics Chief Resident here at the University of Minnesota. During this year, I have grown a lot in many, many ways, and I am grateful to the division leadership for the opportunities they've given me to explore my research interests and to find my path as a clinician educator. And I just feel like I've been surrounded by great mentors who inspire me in very many ways by their zeal, their commitment, and their humility, and just the great accomplishments that you all have done. I'm really thankful to be associated with this group. Throughout this year, I've been involved in many research and educational projects, and I just thought the best use of this time would be to give you a sense of what my time in Cameroon was like. So I would be sharing 3 clinical cases with you to illustrate what my Cameroon was like for me, and I would be happy to share more patient stories because there are hundreds of them. But during this year, during the 4 months I spent at Mbingo Baptist Hospital, Cameroon, which is the place I'm pointing to down in that beautiful lush valley surrounded by hills, I got to wear very many different hats. I was neonatologist, sometimes nephrologist, cardiologist, and intensivist, and then other times the general pediatrician that I signed up to be when I came into residency. It was both humbling and rewarding to have to fulfill so many roles, and I felt a lot of support from specialists whom I contacted very, very many times, and you'll hear a little bit more about that as I go on with the presentation. Mbingo Baptist Hospital is in Cameroon, like Richard mentioned. It's in the northwest region, and it's a mission hospital that was established by the Cameroon Baptist Convention, which started off as a leprosy settlement back in 1952, and now serves as a referral hospital for the region. People come from as far away as Chad, Central African Republic, Nigeria, to Mbingo to receive care. It has over 290 beds, and we had about 30 pediatric beds, 22 beds in the general pediatric ward, and then some when we had to use stretchers to fit in patients that could not fit on the regular hospital beds. So the first case I would be sharing with you is a young man that was introduced to Dustin and I when less than 24 hours after we arrived at Bingo. I got a call from the acting pediatrician about this term neonate who had pathologic jaundice and had been started on phototherapy at 15 hours of life for a total bilirubin of 16.8. But the bilirubin continued to rise despite phototherapy to 26 by the time he was 48 hours old. He was clearly in need of exchange blood transfusion. He was also beginning to show signs of acute bilirubin encephalopathy with sundowning of his eyes, increased muscle tone, decreased feeding, and his prognosis would have been poor if we were not able to exchange his blood. The acting pediatrician had never done an exchange blood transfusion before, and I had only had a chance to participate in one as a medical student about 10 years prior in Nigeria, which is much less than many of my colleagues get to do in Nigeria. Babies get exchanged about 2-3 times a week. Different babies rotate through the exchange blood transfusion table. We had a special place for them, but for me, I had only participated in one. But prior to going to Cameroon, we had our pre-departure orientation and had been introduced to the Sugar Prep website, which is a website that was developed by the Midwest Consortium of Global Health Educators. And it's a treasure of rich resources and instructional videos for adapting procedures to resource-limited settings using materials that are commonly available in these settings. And it has served hundreds of US pediatricians who are working abroad, as well as our local colleagues who are promoting the video and sharing it amongst themselves too. So when Dustin and I were told about this young man, we went to sugarprep.org to review the videos and went back over the simulations that we had gone through that were led by Dr. Slusher here. And then we were able to successfully exchange the young man's blood. We did a almost double volume exchange because the NG tube that we're using as our umbilical vein catheter got dislodged a few times in the process. And after 75% exchange, we thought it was good. His bilirubin decreased to 20 after the procedure. And our baby still ended up needing phototherapy for 6 additional days because he was actively hemolyzing. We made his phototherapy as intensive as possible because we had a bilirubin meter that we were able to use to measure the irradiance. And he went home happy and healthy. As you might be able to see from this picture overlaid in the background, he was a thriving and healthy 3.5-month-old when the last time I saw him about a week before I left Cameroon, and his mom was just really thankful. The second case I want to share is one that still breaks my heart. He was a 5-year-old male with carotid artery pseudoaneurysm, and he died as a result of upper airway obstruction. I had never heard of carotid artery pseudoaneurysm before I met him. And so when his primary admitting team discounted the ultrasound finding, suggesting the diagnosis, I didn't question them. However, the patient's mass rapidly progressed within 36 hours of admission, and he needed to be emergently intubated on a Sunday evening. After intubation, multiple biopsies were performed by the ENT team to try and confirm their provisional diagnosis, and my diagnosis too of Burkitt's lymphoma, because I agreed that that was the most likely cause of a left-sided neck swelling that had rapidly progressed in this environment for a 5-year-old. However, the biopsies did not show any cancerous cells. So I went back to the books and the internet and was reading more about carotid artery pseudoaneurysm, and it turned out I felt this was probably the diagnosis for our patients, and we needed to do a CT angiogram, which thankfully was available in that environment, but not at 1 a.m. on Monday morning. Before we could get him to the CT scanner, the patient self-extubated during the night and could not be reintubated. This experience led me to go back and perform a root cause analysis with the ENT team that had admitted him, the ICU nurses that had taken care of him that night, and the resident doctors that worked with the patients during the time. James Reason, a British psychologist, came up with the Swiss cheese model, and it's a model I identify a lot with and I've talked about a lot because I feel like it helps us to see how latent errors in the health system can come together with active errors by flawed individuals, which is every one of us in healthcare, to cause patient safety breaches and sometimes disastrous consequences for our patients. And errors could be considered inevitable, but what we as health professionals get to do is to think about how we can minimize those errors by putting in system changes, and that was something we got to do in Cameroon as a result of this patient experience. I refused to accept that his death was inevitable, so I discussed with everybody that I felt was involved with the case, and we felt his immediate cause of death was obviously the loss of his airway. But the dose of his sedation was questionable, as the visiting pediatric nephrologist who was helping me out that weekend had suggested a dose that would have been high enough to cause sedation, but the ICU nurses were very reluctant to start at that dose. So they started off at a lower dose and were going to titrate up, and I don't know how much of that happened. The other thing was that he was bleeding significantly after the surgery and needed a blood transfusion that night. We didn't perform an autopsy, but we discussed in a mortality review conference with all the hospital surgeons, internal medicine attendants, resident doctors, and medical students. I led that discussion to think about how we as medical professionals in that system could avoid such occurrences from taking place again. And this patient's experience helped us to save 3 other patients who came in with upper airway obstruction. It was as though we were running a special on upper airway obstruction. Shortly after this young man died, we had a patient with a diagnosis that I'll be sharing with you later on, a second one who came in with a congenital TMJ ankylosis and needed surgical release. She had a post-operative edema and needed to be intubated for ventilation. We also had a patient with a horrible retropharyngeal abscess who also needed mechanical ventilation, and they all survived. And they somewhat redeemed the first patient's experience for me, even though I would never forget him. So this is my third patient that I wanted to share with you today. He's a 7-year-old male who came in to Imbingo Baptist Hospital with 4 days of throat pain, 3 days of cough and runny nose, and 2 days of decreased oral intake as a result of pain in his throat. Within about 3 hours after he came in, he needed to be emergently intubated because he lost his airway. And we did not have, as you might be able to tell from the previous picture, I'm sorry I didn't mention that, he had grayish-white pseudomembranes all over his oropharynx. And the ENT team and I decided this young man had diphtheria, and this diagnosis was confirmed by histopathology and a gram stain subsequently of the pseudomembranes. We didn't have diphtheria antitoxin to give him, but we had IV penicillin and oral erythromycin, which we gave him through an NG tube that was placed. He needed to be mechanically ventilated for 2 days and then developed pneumonia. And with our desire to win his sedation and to have him participate more in his own healing, we decided to place a tracheostomy tube, also based on experiences of people that are taking care of a lot of diphtheria cases, which was not me prior to meeting this young man. By the hospital day 3, he got a tracheostomy tube, needed another 3 days of mechanical ventilation through the trach because he had developed horrible pneumonia by that point. And after 3 days on that, we were able to win him to blow-by oxygen. You might be able to tell from the picture, we had a modified blow-by oxygen, just placing a face mask on his trachea. That was our trach dome. And hospital day 9, he still had some pseudomembranes in his throat, still did not have a patent enough airway to be decannulated. But by 3 weeks, we were able to successfully decannulate him, and he went home smiling and wearing a sticker from my daughter. He had come in a day prior to Easter. That's why the slide is tagged the way it is. It was all clear. This was his oral filings at the time of discharge. To complete this presentation, I would like to thank my wife, Christine, and daughter, Molayo, for coming with me on this adventure to Cameroon and loaning me to the hospital for 15 weeks. My daughter once asked me where my house was. And I also want to thank my parents who are watching online right now and my parents-in-law who continue to support and encourage us. I'm grateful to the many, many pediatric subspecialists and staff here at the University of Minnesota and our affiliate sites who got a lot of calls and SOS texts from me, just asking questions and wondering what next we could do to help our patients. In fact, we had a conference call once when Dustin and I were there to discuss a patient where we had 5 specialists on the phone. It was just amazing to have such support from home. This experience would not have been possible if not for the great staff and dedication of the many workers at Mbingo Baptist Hospital. Many of these people are doing their work as a service to God, and they take it as a mission to be able to serve people who are underserved in this environment. And many people would not be able to access the kind of professional specialist care if Mbingo Baptist Hospital was not there. So I'm really grateful to them for the work they do. I think about the work they do and I just doff my hat to them, and they remain heroes in my opinion. I felt, like I mentioned before, strong support by our division leadership here. Cindy sent us a care package and Easter bunny to my daughter. Dr. Slosher, I'm sure, felt many times that she wasn't in Bingo herself from the many calls she got from me and texts and like, oh, Tina, oh my goodness. And the many people that supported this trip in terms of funds, Baptist Medical and Dental Fellowship, and our Global Pediatrics Division. Thank you all for being a part of this work. Thank you to our residency leadership for encouraging texts from Dr. Bowman Shope and the emails I got from Mike Pitt. Everybody just felt really great. I felt like I was not doing this alone. Dustin Hansen came with me from the very beginning and spent a month at Mbingo, and I felt like we were able to go through a lot of that adjustment together, and it was just a really great experience. Thank you all.
Thank you, Ife. Our next resident speaker is Dr. Rachel DeVries. She's a pediatric resident, completing her pediatric residency, and has a longstanding love for travel and cultural studies. As a medical student, she traveled and worked in India and Uganda, and she believes that global health issues are extremely important domestically as well. As she starts off her career, she is grateful for the knowledge and perspectives that she will be carrying with her forth from here from her global health background. I'll pass it away to you.
Hi, everyone. As you heard, I'm Rachel DeVries, and I'm a third-year pediatric resident. As you've heard from Andrew and Ife, there are amazing global health opportunities that you can do internationally, but there's also other ways to be involved in global health. As our country continues to become more diverse, we are experiencing a significant amount of global health in our own backyard. A great intersection between global health and local experiences for me has been serving for the underserved populations, including immigrants and refugees in our local community. This passion for serving my local community and my need to stay local due to having an infant at home, I was able to explore local opportunities with the Minnesota Department of Health. I connected with Dr. Malini De Silva in the Infectious Disease, Epidemiology, and Prevention Control Division of the Minnesota Department of Health. Within this division, they have a refugee health unit that I worked with on food safety in 3 specific refugee populations, including Somali, Karen, and Hmong. Before we go into more detail, I just want to pause and talk about a couple definitions. So a refugee is a person who has been forced to leave their country to escape from war, persecution, or natural disaster. There has been a significant amount of work done recently around food security and screening for food security. Specifically, I've also been part of this with Dr. Cutts at HCMC. However, this project is not about food security, but rather food safety. Food safety meaning handling and processing and storing foods in appropriate ways to prevent foodborne illness. The United Nations Refugee Agency created this infographic to help you get a scope of the volume of people that are affected by being forcibly displaced around the world. Currently, there are 65.6 million people forcibly displaced around the world. 10 million people are stateless, meaning that they have been denied a nationality and access to basic rights such as education, healthcare, employment, and freedom of movement. 22.5 million people are refugees, but only 189,300 of those are resettled. This means that less than 1% of all refugees around the world are resettled. To give you a scope of this issue, 1 in every 113 people on Earth are asylum seekers, internationally displaced, or refugees. Just to clarify, an asylum seeker is a person who has left their home country as a political refugee and is seeking asylum in another. An internationally displaced person is someone that has been forced out of their home but still remains in their original country. 50% of all refugees are less than 18 years old. This means that there are about 11 million children worldwide that are refugees. Refugees resettle in many countries around the world and within many states in the United States. But thinking specifically about Minnesota, this graph shows what countries refugees have come to Minnesota from over the years. And just to point out, this is based on where the refugees originally resettle in the U.S. But like you or I, many refugees will relocate within the U.S. once they're here, and then they're deemed secondary refugees. As you can see, in the 1980s, most refugees were from Southeast Asia. In the 1990s, we had a large increase in our refugees from sub-Saharan Africa, and then in the 2000s, we continue to see some Southeast Asians and Africans. This map shows you where primary refugees are being resettled in Minnesota. In 2016, which is when this map is from, Ramsey County received the largest number of arrivals, followed by Hennepin, Stearns, and Anoka County. Throughout the years, the refugees have started to resettle in more rural areas in Minnesota rather than just the Twin Cities like previously. In 2016, 45% of refugees coming to Minnesota were from Somalia and about 21% from Burma, which is why we chose to focus this project on Somali, Karen, and Hmong populations. So before I continue, I just want to take a pause and have you guys imagine what it's like to be a refugee. So imagine that you are Karen and you're living in Burma. However, there's conflict going on and you're forcibly displaced from your home. You walk along dirt roads with your family and a few precious items from your home. You've been walking for days until you finally reach the refugee camp. When you arrive, it's filled with overcrowded people and straw huts, and there's barely any room for you. There's limited food, and you likely don't get to decide what you eat. You get served small meals each day, and in some camps maybe have limited access to supplies to cook. You spend your days waiting for your application to go through its extensive process so that you can get out of this camp. While you wait, I just want to walk through what happens when you submit an application to be a refugee. So because you fled from your home, you're now considered a refugee. You then will register with United Nations Refugee Agency and are referred to a refugee admission program within the specific country you are looking to resettle in, such as the U.S. Each country has a slightly different process, but we'll go through approximately what happens in the United States. So your application will go through security checkpoints in the Department of Homeland Security, the FBI, the State Department, and the CIA. The Department of Homeland Security will then go through interviews and biometric security checks. If you pass all of this, then a CDC physician will undergo your overseas medical exam. Again, if you pass, you then get matched with a resettlement agency. Travel is then arranged, which once you arrive to the U.S., you'll have to pay back. However, each day you continue to wait in that resettlement camp, and travel arrangements can take years to go through. The average wait time from the beginning of this process until final relocation, according to the UN Refugee Agency, is 17 years. Once you get on your plane and you land in the U.S., you're greeted by your resettlement agency. You have 3 months to work with a caseworker, and this person is the person that will help you learn basic cultural tips, how to navigate the area, how to buy food, and show you around your new house or apartment. Okay, so now we're in the U.S., and you walk into a grocery store, potentially a store that you've never been in before. Food is in unusual packages with labels and dates, so you pick up some food and take it back to your home. In your kitchen is a refrigerator and a freezer, but you've never seen such an appliance before and you don't know what to do with it. So to be safe, you take all of your newly purchased food and put it in the refrigerator. So now shifting to the actual project that I did. Before I arrived with the Minnesota Department of Health, it had partnered with the city of Minneapolis and created 3 focus groups to gather information about cultural norms regarding how these cultures handle food carefully. And specifically, they worked with the Somali and Latino communities. The focus groups were conducted in the participants' primary language, and the group leaders were also of the respective ethnicity to try to decrease any barriers for communication. So once I arrived, I used this information and then partnered with community-based organizations and resettlement agencies. The community-based organizations I worked with were the Minnesota Department of Health, the Karen Organization of Minnesota, and Ramsey County. The resettlement agencies I worked with were the Minnesota Council for Churches, the International Institute of Minnesota, and Lutheran Social Services. Based on my conversations with these groups, I was able to create a needs assessment for the 3 communities that are of interest. I learned that one of the biggest knowledge gaps in the Hmong community was that they were serving often undercooked beef at large gatherings such as funerals. In the Karen population, they tend to prepare food in the morning and leave it out the rest of the day for their family to eat. They also don't often close their containers such as rice, sugar, or flour, which increases the risk for pest contamination. Somalis are often good about washing their dishes between cutting raw meat and vegetables, but often washing means just with water and not soap. Many people in all 3 of these communities will leave their milk out at room temperature all the time. In general, there was a lack of knowledge about bacteria and what germ theory is. So when I talked to the case managers at the resettlement agencies, we talked about what was the best way to disseminate the information that we needed to about food safety. They specifically requested magnets to go on the refrigerator, freezer, and pantry to show where food should go, handouts for families about food safety, a food safety checklist that the resettlement caseworker could walk through with the clients, and a food demonstration. So now I'm going to show you the materials that we were able to create. So I did develop these 3 magnets that they requested. Here's a template of what the refrigerator magnet looks like. The final product, however, we'll still need to go through communications and we'll probably get rid of the date ranges because there's a big concern that given the minimal funds that these people have, that at the end of the date, on the date range, they will just automatically throw the food away. So as you can see at the bottom, we tried to create a guideline for when people should be throwing their food away rather than just specifically how long it's been in the refrigerator. We purposely organized this magnet this way to try to put the raw meats toward the bottom as to try to prevent cross-contamination with the meat drippings on your other foods. Here's a rough draft of what the freezer magnet looks like. This magnet was actually particularly difficult because many of the foods that we would put in the freezer could also go in the refrigerator. And so the team that's continuing to work on this may choose not to use this one since there isn't specific food safety guidelines about the freezer. However, we got huge push from the case managers to include this magnet, so that's why we have it at this point. And then the last of the 3 magnets is for the pantry. And specifically here, we're trying to just point out foods that don't need to be kept cold and to encourage people to keep their bags closed, such as rice, flour, and sugar. This Be a Germ Buster handout was a handout that was already created by MDH prior to my arrival and is going to be used to demonstrate proper hand washing. Then the plan is to take these cute little green germ guys and use them on this cross-contamination handout for consistency. Here we're trying to show the importance of cleaning your cutting board and knife after cutting raw meat and before cutting your raw vegetables, because the cooking process of the meat will kill the germs, whereas if you have the germs on your raw vegetables, you're just going to eat that bacteria. The food safety checklist that I created is about a page long and is organized by brief descriptions about germs, buying groceries, storing, preparing, cooking, and cleaning up foods. And then under each of those headings are a couple key points that the case managers can talk to the clients about. Next steps for this project include, like I mentioned, sending it all to the communications department. And then it's going to be translated into Somali, Hmong, and Karen. There's an ongoing plan for creating a cooking demonstration to walk through key elements of food safety while preparing food. Some ideas for this cooking demonstration includes using glow gel to represent germs and show how the gel disappears with washing or cooking of foods. This demonstration will be a great way to communicate in people's native language and allow for more interaction and ability to answer questions, especially in these oral cultures. The last piece that I want to touch on is the Minnesota Department of Health physician rotation. Prior to my time in this project, I didn't even know that this project existed. And MDH puts on a 2-day educational seminar every quarter where they have MDH employees give about 30-minute talks on different specialties that they participate in at MDH and what they can do at MDH to help support community physicians. This 2 days was an amazing and eye-opening experience for me and made it feel much easier to get in contact with MDH. This year's topics included things such as reportable diseases, refugee health, lead, newborn screening, international travel and emerging infections, vector-borne disease, enteric disease, opioids, and immunizations. I would encourage residents to do this next quarter. Thank you to my entire group at MDH, including Dr. Malini De Silva, Blaine Mamu, Marge Higgins, Shelby Pantaja, Ann Lindy, and Amy Saup.
Thank you, Rachel. Our last resident speaker is Dr. Joe Wooley, who, like all of our speakers, has a longstanding interest in global health and recently has developed an interest in Native American health.
Good morning. Thank you all for being here, and thank you for the opportunity to share my global health experience. Thanks, Mike, for the new cane. I'm sure there's a joke here with Rosebud as the punchline, but it's just not coming to me. And thank you, Risha, for the introduction. It's really an honor to be here to talk to you, especially amongst such amazingly talented and accomplished colleagues. I'm humbled that I was asked to be here, so thank you for that. In the interest of time and the fact that I can only stand up for so long comfortably, I'm just going to kind of jump right into things. I'll give you the fair warning that there are no other slides, so you'll just have to get comfortable with this. A couple months ago, I returned from my global health rotation in Rosebud, South Dakota, where I worked on the Lakota reservation there with the Indian Health Services. And this was really my first experience rotating with an American Indian reservation, and that's because my historical interest in global health had always been in Central and South America, because that's where the formative experiences that really shaped my interest in global health and I guess medicine in general were had. So it was only after my previously scheduled rotation to Central America fell through at the very last minute that this whole idea of rotating on a reservation was even brought to light. But I really can't overstate how grateful I am that things worked out the way that they did, or didn't, because it turned out to be an incredibly eye-opening experience that has certainly changed not only my career trajectory, but who I am as a person. So, thinking about what Rachel was talking about, global health at home, it was a nice segue for what I'm going to talk about. But I think it's important to start with the caveat that 10 to 12 minutes is just not enough time to really describe the historical basis for the current health inequity that exists for Native Americans, much less to understand the context for which that injustice is allowed to persist. But I do think it's important to recognize and probably imperative to understand that this is an obligation that our country has to this community to help remedy some of the damage that's been incurred. The downstream effect of that tragic history is that Native Americans have come to represent the lowest ranked demographic by almost every single metric of healthcare status compared to other Americans. Now, barriers to care and devastating social conditions have led to a severely truncated life expectancy and an absolutely disproportionate disease burden. This community is plagued by high rates of incarceration and chemical dependency and harsh economic conditions, which lead to things like housing instability and food insecurity, which are unfortunately commonplace. And as a result, the pediatric population is steeped in a level of toxic stress that is just unimaginable in this country. We see that reflected by their poor nutritional status, their appallingly low graduation rates, rampant drug abuse and gang involvement, and of course, their sky-high rates of depression and suicidality. I know much of this is reminiscent of many of the international global sites that we're more familiar with, but I think that it's important to recognize that this is different in many ways, and one which I sort of alluded to and Rachel touched on is this idea of global health at home, that this represents not some faraway land where people are oppressed by foreign dictators or theocracies or broken systems, but this is right here at home. This is in our backyard a few hundred miles from here, and this is our history, our broken system that's contributed to this. And so Indian Health Services represents a government that has committed unspeakable atrocities and caused historical trauma to this community that is clearly embedded in their epigenetics. And for a non-native provider working as a conduit of that system, the job is incredibly difficult. It requires a level of intentionality towards cultural sensitivities and really working hard to build some sort of trust and a therapeutic alliance to even start the work. I recognize that when I walk into a patient room that there's an inherent sense of distrust. And that's a large task to overcome when you're trying to provide for kids, especially in the context of a community that doesn't seek routine health care and are only really seen for acute visits. And so it makes that window for creating rapport impossibly small. As the first University of Minnesota resident to rotate through Rosebud in any official capacity, there really was no framework for my clinical experience or my cultural opportunities, and so much of what I did was just sort of made up as I went along. And ultimately, I spent the majority of my clinical time in the outpatient pediatric clinic where I worked Monday through Friday, 7 to 7, and then had additional 24/7 on-call responsibilities for emergency department consultations and hospital admissions, although I'll tell you that the majority of pediatric patients requiring admission are ultimately transferred to hospitals off the reservation. That's due to a lack of capacity of the hospital, both in terms of number of beds and ability to handle any sort of acuity. Additionally, over the past couple of years, the hospital has suffered some pretty major setbacks, and as a result, the operating room is on diversion indefinitely. And so without C-section capabilities, all deliveries, regardless of their risk, are also transferred off the reservation. So thinking about how the nearest freestanding children's hospital is over 3.5 hours away, you can understand how much of a burden this places on an already strained system. Transportation on the reservation is no easier, as the average commute to the hospital and clinic is over an hour, which might not sound like much, especially if you're coming from the East Coast. But in a setting where there's no public transportation and the majority of people don't have access to a car, that can be insurmountable. Another major barrier is cost, as it is everywhere else. The government provides funding for Indian Health Services as well as Medicaid, which most pediatric patients qualify for, as well as something called Preferred Care Referrals, which is a fund that's set up to help subsidize healthcare costs to tribal members who require services that aren't available on the reservation, which for pediatric specialty care is literally everything. The problem is that because this fund is annually determinate and incredibly limited, it becomes a first come, first serve, highest acuity basis. And I recognized pretty early on that if you weren't prioritizing somebody as a level 1, which is supposed to be reserved for life, limb, or sight-threatening illness, it likely would not be approved and therefore not paid for. So as a clinician, you can identify a problem and make a referral, but unless it's an emergent one, it probably won't be approved or paid for. And so pediatric care on the whole is not only inaccessible, it's also unaffordable. In the limited time that I have, I just wanted to highlight one of the many major challenges that I faced in Rosebud, and that's that while I was there, the community was suffering a spate of teenage suicides. This isn't a new phenomena to this population, and unfortunately in Rosebud, this occurs in sort of a cyclical manner, what I call an acute on chronic mental health crisis. Just so happened that I was there during one of these episodes. And before I left, I was able to collect some data from the emergency department for just the time that I was there. And I was shocked to find that in that short period, there was over 30 emergency department visits for suicidal ideation with a plan. There's over 15 suicide attempts, and unfortunately there were 3 completions, all within the teen and young adult population. Now, in a community that makes up no more than 25 or 30,000 people, that number is astronomical. And because of the tight-knit nature of the community, it's palpable. It was impossible to ignore the countless cars in the parking lots and the roadways with window paint memorializing recently lost tribal members, or the overwhelming majority of adolescent patients that I saw in clinic with overt signs of self-harm. I took it upon myself to institute mental health screenings for all patients over 10, regardless of what they came in for, in hopes of doing something, and was shocked within a week I had double digits of kids who met criteria for severe depressive disorders in children as young as grade school. And then what? Thinking back, I'm saddened to think that that only represents the tip of the iceberg, because those were the kids who were lucky enough to have access to clinic. And for every one of them, there's probably scores more in the community that are steeped in the same toxic stress. They're being exposed to more adverse childhood events than any of us care to think about, who don't have access to even limited resources and are suffering in isolation. I was really disheartened to think about the level of disparity and despair that's allowed to persist in the confines of one of the wealthiest countries in the world. Reflecting on my time, I don't know if there's ever been a time in my residency when I felt more needed. Not because I'm anything special as a clinician, as any of you who have worked with me know, but rather because the human capital need is just overwhelming. And I recognize that the work that I was doing was vitally important to the child in front of me, and if I wasn't there to do it, there probably wasn't somebody else to fill that void. And so, as Dr. Subramanian told me so succinctly when I returned, now the veil has been lifted. And so true, because this is out of sight, out of mind, a largely invisible problem. And because it happens within the confines of the reservation, it's a problem that many don't even recognize exists, or at least to the degree that it does. But I can't ignore what I've seen. I can't move on with my career and pretend that that level of health inequity exists right here in my own backyard. And so I've committed to make American Indian health part of my long-term career plan. And I'm starting to work with the university to help establish Rosebud as a permanent rotation site for the global health track, in hopes of giving other residents similar opportunity to have that type of experience and hopefully be inspired themselves. Because I think this is not another cause worth championing. This is something more. This represents an obligation that our country has failed to fulfill. And I hope that my experience and my story will hopefully inspire at least some of you to consider Native American health in your own careers and how to make that global health at home a reality for you. Thank you.
So we are at the 8:30 mark, but if anyone is interested in asking questions and our residents are willing, I'll give a few minutes here to open it up to questions for our resident speakers. Thank you everyone so much for your meaningful stories, your impactful projects, and what you've brought to our program. If I'll just give it a few more minutes or a minute or so, but just consider if you do have questions. Yes.
Has anyone in the community explored alternative food stoves? Hi. Had anyone in the community that you were in explored alternative cook stoves, or was everyone cooking on a cooking with with fuels on an open flame?
Yeah, most of them. Sorry. Most of them were open flames. I know what you're talking about. I'm aware of kind of like interventions, especially like in Peru is the one I'm most familiar with, about trying to alternative fuels and things like that. But that was something that we tackled when I was on home visits with them. In fact, some of the open flames were like within huts, so where there wasn't like actually good ventilation. That's something that that we were starting to talk to them about. But yeah, it's a good question.
Wow, that was amazing. Every year I'm amazed by what you bring to us, so thank you very much. My question is about the comment that Joe made, and I realize it's relevant to everyone, and that's about the sense that we as clinicians kind of treat a person in front of us and how it's easy to get lost in the vastness of the problems that the populations face. And I experience that regularly in my work with kids of abuse and neglect. And I'm wondering how you address that in the global health program, where really the situation is unimaginable to many of us, and yet we still feel like we need to feel like we're making a difference with one person. What do you do to keep that going? To keep from feeling overwhelmed?
The short answer is, we can't. We have to acknowledge that is a feeling, and we do a lot of work about specifically culture shock, like the fact that when you're working in another culture, especially going from high to low resource, so we know this happens in both directions. We try to prepare you for some of the internal strife that causes. We've increasingly, Ben Trappe has been talking about looking at moral distress, and when we're struggling with having to make decisions that feel like they're the wrong decisions based on the patient in front of us or the resources that are available. But I think it's actually just being transparent that how hard that work is. We probably don't do that enough stateside, but we do try to make that a priority within the track.
And I'll just add that we strive to make our partnerships sustainable, so that we're developing relationships with folks that we're working with, and one of the major objectives of this day is to encourage our faculty and younger junior residents to be involved in these partnerships, and of course to celebrate the victories, which Ife pointed out so well, to learn from mistakes and try to make things better with colleagues wherever we're working.
You have been disconnected from the meeting.